Good afternoon, good evening, wherever you are. My name is Joan Marston, and I am the Vice President of the Elisabeth Kübler-Ross Foundation Global. We are delighted to welcome you to this historic first collaboration between St. Christopher's Hospice in the UK and the Elisabeth Kübler-Ross Foundation Global that is based on the friendship and the complementary work and vision of those two remarkable pioneers of the hospice palliative care movement, Dame Cicely Sanders and Dr. Elisabeth Kübler-Ross. This session has come about thanks to the vision and actions of Rodrigo Luz, our wonderful education lead and board member of the Elisabeth Kübler-Ross Foundation Global and the president of the EKR Foundation in Brazil. Thank you so much, dear Rodrigo. It is really fitting that this takes place today on World Hospice and Palliative Care Day, when the second edition of the Global Atlas of Palliative Care has been launched and is available on the Worldwide Hospice Palliative Care Alliance website. Led by Dr. Stephen Connor, the Executive Director of WHPCA and a board member of EKR Foundation Global, it shows us that 64% of the countries in the world have little or no access to palliative care. So while we celebrate the remarkable work of our pioneers and all that has been done, there remains a great deal to be done. And so it is my pleasure now to briefly introduce you to our interviewer and our panelists from St. Christopher's Hospice and the Elisabeth Kübler-Ross Foundation. We will put their bios on the website, so I'm just going to very briefly introduce them. From St. Christopher's, we are really delighted to have with us Liz Bryant, who is a Senior Education Associate and was the previous Director of Education and Training. She is a palliative care nurse, an educator, and an education assessor. And we also have with us the Reverend Dr. Andrew Goodhead. Andrew, I see you have a nickname, the Running Rev. I love that. He is St. Christopher's spiritual care lead, and he is very concerned that every member of the team that cares for patients and families have the knowledge and the skills to do the assessment and ongoing support in spiritual care of patients and family. And then from the Elisabeth Kübler-Ross Foundation, we have Ken Ross, who is our president and also the son of Elisabeth Kübler-Ross and who knows her so well. He is also an extraordinary photographer. And our interviewer is Diane Gray, who is a board member of the Elisabeth Kübler-Ross Foundation, our director of communications, and a global ambassador of the International Children's Palliative Care Network. We invite you to put your comments and your questions in the chat. And with that, I hand over to Diane and to our wonderful panel.
Thank you, Joan.
Joan, thank you so much. And I want to welcome all of you here today. This is, as Joan said, it's a historic union and a meeting of not just our organizations, but our global community of citizens and individuals who really are working so hard to not only bring a greater awareness of what palliative care is, but greater awareness to the potential for unconditional love, for spiritual care, for medical care, for all types of care, for not just seriously ill individuals, but for those who are truly suffering. So with that said, I'd like to ask some questions of not just Ken Ross, but of the entire organization and the panel here. First of all, Ken, can you start us a little bit? I know a bit about your mom's history, but for those people that do not, can you talk about when your mom was a young woman and she went to rebuild war-torn Europe? And I think this is an important way to start our conversation here, and we'll segue into Dame Cicely Sanders' profound work at about that same time, you know, and what her observations were. Ken, can you talk about what your mom saw as a young woman when she went to rebuild war-torn Europe and how that implanted the seeds of the work to come?
Well, as some of you know, the day after the war ended, Elisabeth, as a teenage girl, joined a peace group, and she ended up traveling around Europe for 2 years as a teenage girl by herself, if you can imagine. I mean, crazy story, but she just loved it and she thrived, and she was rebuilding villages. She was helping people in limited medical ways. And eventually, after about 1.5 years, she ended up in Poland. She'd had a Polish professor who really imparted upon her how the Polish people had such a terrible struggle.
Mm-hmm.
So she ended up in Poland, and she just heard so many horrendous stories. She had to go to the concentration camps and see for herself what had happened. So she ended up in Majdanek, and it was just a horrific experience. You could still smell the gas chambers. There were still carloads of children's toys and hair and glasses and teeth. So anyway, from that experience, spending several days there, she really began wondering about the meaning of humanity and suffering and what we can take away and how things need to change. It's kind of a version of logotherapy, right? She's good friends with Viktor Frankl and Cicely Saunders too, finding meaning from suffering and how we can change all this. Mm-hmm. And so that really inspired her to go to medical school and try to do something about the human condition. So it really set the whole tone for the rest of her life.
Thank you. Liz, can you address a little bit about what Dame Cicely Saunders also saw that became formative in her ideas and concepts going forward?
Yeah, so Cicely came from a very privileged background. She was at an all-girls school, Rodine, and she was very bright. She went to Oxford, which was quite unusual in those days for women to study. And she was studying PPE, so politics and economics. And she'd had a sort of spiritual experience, and very early at the beginning of the war decided that she couldn't stay as a student and wanted to be a nurse. And it was as a nurse at St. Thomas's doing her training that she was obviously witnessed the Blitz, the bombing in London, the suffering, as well as patients with cancers. And I think that really impacted her in terms of just really feeling that she wanted to respond somehow. And, as a nurse myself, I'm very aware that she absolutely loved nursing. She really enjoyed being a nurse, but unfortunately had to give it up because of her own physical limitation. She had terrible back problems, so was forced ultimately to give up nursing, but was so committed to being alongside people who were suffering that she went back to Oxford and studied social work, and then became initially an almoner, which in those days was very much focused on helping people with their financial situations to pay for their healthcare. But it ultimately, because of the war, and as I was saying earlier, because we in the UK responded, there was a real social movement, and we had the National Health Service began as a result of, I think, learning and the impact of the suffering through the war. Her role moved from one of just looking at finances, and obviously everybody was then entitled to health and social care at the point of delivery. So her role as a social worker became much more around the emotional and social well-being of people. So that really suited her very well. She wanted to be present in the face of suffering.
So powerful, right? I wish that they were here now and could segue that knowledge and wisdom forward. So to both you and Ken, I'd like to ask, with everything that we're going through now, You know, people are frequently very, very quick to say, oh, that's the history, that was then, this is now, nothing is similar, there's nothing the same. However, people still die, that's the same. Suffering still exists, that's the same. Trauma still exists. And both Elisabeth and Dame Cicely Saunders bore witness to profound trauma and suffering. To each of you, if you'd like to sort of take turns and step in, what do you think that their message might be to just people in general right now? Both, let me start this way. What do you think their message would be to the medical community, to the clinicians, to the social workers, to the chaplains? What do you think Dame Cicely Saunders' message would be to the current practicing clinicians during this time?
Shall I go first, Ken, with Cicely? I think she'd be quite disappointed and frustrated because there is a sense that 50 years of campaigning, lobbying, trying to educate and influence clinical practice. Certainly our experience here in the UK is that we seem to have gone default back to a biomedical model during COVID. So I think that's been a little bit shocking and quite disappointing for those of us that are part of the palliative care movement. And I think that there's a lot of unspoken suffering, a lot of suffering that's going on in isolation. So today also happens to be World Mental Health Day, and I think that's interesting. I think it's not, it's of equal importance, but I think it's interesting how that certainly is taken in the media, perhaps a little more centre stage than World Hospice and Palliative Care Day, certainly here in the UK. And I think my sense is, and I'm sure Andrew will be able to add to this, is that death and dying is always going to be an existential anxiety for humankind. So whatever we do, we're always going to be having to push and drive this sense of we need to be talking about what death means, what suffering means. And that's not going to go away. I don't think we'll ever be able to take our foot off the pedal in terms of promoting better care for the dying, because generally people don't want to think about it. They don't want to live in a world where their life is finite. So I think we're the sort of people who really want to talk the truth about mortality and death being inevitable, but we also want to talk about it in terms of hope, and that there is something that can be done. And one of the biggest messages, or the most important messages, is that this idea of having to do it alone doesn't need to be that we face death alone. And Cicely, and I know Elisabeth, were very keen to be present to those that were coming to the end of their life. And we know now that we have a global epidemic of loneliness, incredibly, and that needs to be something that we address.
Thank you. Andrew, I would like to ask you to add on as well onto the concept of the suffering of others, especially during this time. And what would Dame Cicely Saunders say, do you think, to the medical community at this time, as it pertains to both total pain, right? And as well the spiritual, emotional suffering?
Well, I think I've got to phrase myself very carefully, but I think in some senses we don't do suffering anymore, and I don't mean that in a very glib sense of just throwing that out as a meaningless phrase. I think what we tend to do is think that actually everything can be cured, everything can be made better, everything can be improved, and we find it very hard when we're in a place where actually things don't necessarily improve. One of the seminal books for Dame Cicely Saunders was Viktor Frankl's Man's Search for Meaning, and I think we can over-egg that pudding, but we shouldn't. She read it fairly early on when she'd met David Tajma in around 1948, and was clearly aware of the nature of suffering and how you can deal with suffering as an individual. We know a lot more about the experiences of conflict and trauma, so things like PTSD and other mental illnesses and mental health concerns are better understood and better treated. But I think at the moment we are faced with something which is so uncertain, and so that adds a level to our suffering which we don't really ever know any answer to, because we don't deal with uncertainty at an even more fundamental level than suffering, because everything for us is now certain. We could live with the uncertainty of the Cold War, because actually we knew that nothing really would happen potentially. It was all a bit sort of knife edge, but never really too much on a knife edge. But this is very much at that point where we are not in control. And in terms of suffering, I think Cicely would talk about a number of things, one of which would be accompaniment, being with each other and with others. She would also talk about seeking to understand and make sense of what is going on and finding an attitude within that suffering. And that reflects very broadly David Tajma, of course. She'd also reflect back on the people that she spoke to in the early 60s when she was doing her research before St. Christopher's opened, about their life experiences around total pain. And understanding that for those who come with uncertainty and have suffering, and experience suffering rather, there is an element of pain within that. And her book Watch With Me, which has now been translated into lots of different languages, really picks some of that up about the idea that total pain doesn't necessarily mean you have to have experienced all the elements of total pain, but one of them can create that experience for you. And I think Cicely would ask us to be looking out for that, not just be looking at what Liz described as a biomedical model, but actually looking at people as human beings and listening to their story, understanding them as people, recognizing what they are saying. And so I think some of the rhetoric that we're hearing from different places across the globe is unhelpful, because it doesn't engage with people who are indeed facing uncertainty and suffering. What it tries to say is everything is certain and it's okay. And therefore we've a disparity between what we're told and what we know. And that's certainly true, I think, at the moment. And there needs to be an element of truth-telling or recognition of suffering and naming it as exactly what it is, and not burying it or just saying it'll be okay, it'll go away, but actually allowing people to experience it, and ultimately not to say don't worry, because actually just saying that doesn't address somebody's suffering. Allowing the expression and being with and accompanying doesn't take it away, but it means that somebody's not alone. And one of the great things for Cicely and Elisabeth and others who are pioneers of hospice and palliative care is this is not about you being alone.
Brilliant commentary and spot on. One of the things that is fascinating to me, as Liz, you brought up, that this is, also too, Mental Health Day. So one of the things when the language coexists between mental health and, end of life, mental health and hospice or palliative care, they bring it up as, mental illness. And I've always been curious, what if we discuss it as mental wellness, well-being within this end of life journey, well-being and mental wellness as a part, to your point, Andrew, of learning to coexist with suffering rather than just diminishing it and saying that it will go in the corner. I think it's really telling, Liz, to your point, that the 2 days are today, World Hospice and Palliative Care Day, and this day of recognizing that mental health is a part of our existence. Ken, I'd like to turn now to you, and I'd like to ask you about, you know, your mom's thoughts. What do you think your mom would say to clinicians? And then subsequently, what do you feel that your mom would say to the world as a whole in terms of these very special times that we're living in?
Well, as Liz said, both Cicely and Elizabeth and Balfour Mount and Florence Wald and all those wonderful pioneers, they opened up the stage for doing this incredible care around the world. And it was heading in a great direction, I think, for in the 60s, 70s, 80s, but then it seemed to go off the rails because now everyone's concerned about rules, regulations, and so forth. And it's completely gone in a direction, she would not like, with Cicely would not like, with for-profit hospices, things like that. And she'd say, as technology develops, we get away from our humanity. And so Elizabeth was always about circling back and simplifying. Stop making it so complicated. Sit down on the bed and be a person. Listen to them, listen to the patients. Forget about all the technology, forget about reimbursement, forget about all these things which distract us from the main message, is that you have to be present with the dying patients, and she would just be horrified, as I'm sure Cicely would, what's going on now, because there's so many distractions and so many, again, just like in the 60s, the promise of technology will save you. And that's just not true. It'll delay it maybe, but it's not the answer. The answer is humanity, and technology pulls you away from humanity. It's just a fact, So we've got to circle back, we've got to simplify and just be patient focused.
Yeah, that's so true. What do you think going forward, to all of you? Going forward, these are obviously difficult times, but these will not be the only difficult times that, to your point, humanity endures. Elizabeth and Cicely Saunders both saw profound suffering in the past. So let's look forward. What do you think they might say would be just some of the lessons that we could take away from this unique time of coping with not just COVID, but profound suffering globally? What do you feel your mom would say to humanity at large right now?
Well, she'd say, look back to the AIDS crisis, because she says this is very, very similar. It's parallels the AIDS crisis, when there was so much misinformation, so much fear, so much anger. We're not focusing on this in a healthy way. This is time for us to come together and not have a fragmented society like we're seeing now. So she would say this is an important lesson for us to separate the wheat from the chaff. We can take lessons like she learned from the concentration camps, like Victor learned, like Cicely learned. We have a choice what to do with hardship. We can move forward or we can move backward. We can retreat or we can use it as an opportunity to grow and learn. And so she'd say, please, let's focus on growth now. This is possible. It's not only a bad thing. All challenges are opportunities for us to grow and be better people, be a better society. And so, remember those lessons and learn from this.
Thank you. That's a brilliant point too. And it's interesting that Cicely Saunders and you all spoke about Viktor Frankl's profound book, Man's Search for Meaning. It changed my life. It still sits on my nightstand. There's another book that has just been published recently about saying yes. And that too is by Viktor Frankl. But Man's Search for Meaning was instrumental to both Elisabeth and to Cicely. And those lessons, for those of you that are listening that haven't read that book, I ask you to check it out, to read it. It was a brilliant book. It's a short read. It's one that will give you food for thought and food for your spirit as well. Liz, I'd like to ask you and Andrew both. What do you think Cicely would say to today's society and looking forward? Because again, this is not going to be the last difficult time or difficult era for society or humanity. What do you think Cicely would say?
That's quite a difficult question to answer.
Sorry.
Yeah. There's no doubt she'd have plenty to say. I think it's really interesting. I was doing a sort of little bit of reading around, and I came across. I understand that Cicely, towards the end of her life, had to write 1,000 words on Elisabeth, and she described them as themselves as like the two blades of a pair of scissors. And you know, Elisabeth, yeah, there we are. Yeah, that Elisabeth, I'm assuming that she said one focused on changing public attitudes, the other on the recognition that pain could be overcome. So I'm assuming that Elisabeth was the former and Cicely was the latter. But I actually think that Cicely, towards the end of her life, was becoming very aware that maybe becoming a medical specialism had been, I don't think she would say it was a retrograde step, but it has led inadvertently to the over-medicalization of dying. I mean, it was necessary to develop, you know, sort of medical expertise in terms of pharmacology and managing physical symptoms, but only because if physical symptoms are managed, then people can do the work on their spiritual, their social and their emotional well-being towards the end of life. And yeah, so suffering is not just the physical, it's the whole total pain thing again. And I think that Cicely would probably say, rather than developing specialism, we need to go back to undergraduate training for doctors, social workers, nurses, anyone who's involved in health and social care, and make sure we're having these open conversations about suffering, mortality, managing dying, and talking in a much more from a philosophical and social sciences perspective. Again, there's another lovely quote in David Clarke's book about how, you know, science is about getting to know things so that we can use them, and art is about getting to know things so that we can know them. And I think that we need to, you know, death is not something that happens to other people. You know, if I'm, as a nurse, if I care for somebody with a broken leg, I may never break my leg. But if I'm caring for somebody and involved in somebody else's journey at end of life, it's something that, you know, is going to happen to me too. It's something we all share. And we should be having, I think, these conversations at an undergraduate level so that we increase the sort of our death literacy, you know, our ability to find language to speak about these things that we avoid talking about because we don't have the language and we're constantly afraid of upsetting one another. And I don't know what you think, Andrew, but I think Cicely would have, I think she recognised, didn't she, that it needed to be much more integrated across mainstream healthcare.
Yes. Absolutely right. I think one of the things which we must hold always in mind is that Cicely would not have just made a pronouncement, and the same would be true for Elisabeth Kübler-Ross. I think there would have been some element of, let's hear what the people who are experiencing this have to tell us. And at the present time, what we're hearing is generally people who are not experiencing this telling us what we need to know or what they think we need to know. So we're not hearing actually the full extent of what the current pandemic means. And we don't think about it in terms of meaning. We think about it in terms of our economy, in terms of trade. We think about it in terms of death, which obviously is a very big part of it because that affects individuals and families and communities. And we think about it in lots of ways which are all separated out rather than as one thing. And Cicely would say, actually, they're all together. There's a quote which she brings from her research back in the 1960s when before St Christopher's opened, where she was talking to somebody then at St Joseph's Hospice in Hackney in North London, or East London rather, who described total pain. And described it not only in the physical sense of I could have cried for the medication. She then talked about her son and husband who had to give up their work to care for her, which meant they lost money. They would then have the social experience was equally that her life was diminishing, and ultimately then she was admitted to St Joseph's, and she began to say, actually, now I see what it's all about, because Cicely had taken the time to sit and listen to her. And from that, Cicely then spoke, if you like. So it wasn't just her making or deciding on something, it was listening to other people. But I think it's absolutely right that it comes down and moves out of a secular model of education into something which is broader than that. By that, I don't mean you move to a religious model of education, but a model which accepts and understands there is more to us than sort of a biological being. That when we go to the doctor with something, which may be, a pain in our stomach, there may well be something else which affects us hugely. And it's all about hearing that. You might treat the pain in the stomach, but you might also seek to listen to the pain in the heart. And I think we've made specialisms of listening to the pain in the heart as well, to be honest.
Yeah.
And actually, we need to sort of accept that we can all do that together. And share in each other's suffering, or at least understand and be part of that. And Cicely would, I think, really rejoice that there's been so much community action and communitarian work that's gone on in this country, and I'm sure in America too, of people who've just set out to do extraordinary things by the most simple means. And we have a thing in the UK, of course, called the birthday honours, because we still have this rather archaic system of giving people medals. And so a number of those have been sort of honoured for doing very ordinary things, and that's great. A man who works for Asda in the UK, who recognised that elderly housebound people couldn't get out to do their shopping because they were at home, and in his own time with colleagues they bought the shopping, they went to people's homes and delivered it. Now that's dealing with people at the level that Cicely would say we need to work with people. It's not seeing them purely as, well, they're a biological being and they can, they need to look after themselves. The whole idea of hospice, it has to be that there is some sense of community within it.
Can I also add, I think I do a lot of work with colleagues around the world, and one of the things that I'm finding increasingly concerning is that there's a real drive in a lot of countries to develop palliative medicine, which is completely different from the original model of palliative care, which was holistic and interdisciplinary. And I think that she would probably have something to say about that too, that palliative medicine, which is very much about knowing how to prescribe opioids and manage physical symptoms, it may be have a more holistic approach to it, but it's not the same as actually recognizing the discipline of social work, of psychology, of nursing, and although in many countries they won't maybe have all of those roles, paid roles, but recognizing that there's more to the person than the physical, that actually we do have to address, what matters to that person. Who are their family, what is their spirituality, what are their concerns and worries.
It's interesting that we've been discussing this. In 2015, there was some brilliant research from Stanford that basically said this: out of, I think it was 1,047 physicians that responded, 99.9% of the physicians had difficulty responding to patients from a different ethnicity than theirs. 99.9% of the physicians also had difficulty responding to their patients when the patient asked about God. or asked about spiritual care. You know, one of the things that this work has taught me is that medicalized care, to your point, Liz, is often cylindrical. It's often hierarchical, whereas true palliative care and true models of care that both Elisabeth and Cicely would have embraced are circular and community in nature. And I think, Andrew, to your point, and Liz, to yours, and Ken's yours, what we're saying is that we really would like to continue this visualization of the community-based approach, that it's not just one medicalized approach to care. It's more community. And maybe in some countries, they don't have a social worker, a chaplain, you know, the full palliative care team, right? But one person can do their best to embody all of these different aspects of care that include spiritual care, emotional well-being, yes, of course, medical care, pain management, but also how are people getting by in their community, which are aspects of social work. Stephen Covey has a quote. It says that people often listen to respond. They don't listen to understand. And that is consistent with what Cicely and also to Elisabeth felt. The medical-based approach to care is that I'm going to listen to respond, and then I'm going to tell you how we do it. But this listen to understand has to do with this approach, and as well as Viktor Frankl, right? To help people find meaning, to help them find their way through deep and profound suffering, but also too, in this crisis, it will also help the clinicians and the providers and the care community also find equanimity and social justice and a sense of working and waiting, as I say, through suffering. Because to your point, Andrew, I don't think that people ever just park suffering on the side. You're going to get through it. I agree with you completely. That death also too is their great equalizer, and it's the great unifier. To your point about Cicely, I think one of the things as we go through this time of COVID is that too, our traditionally educated clinical teams are being thrust into this death space, ready or not. Nurses, doctors, ER, ICU, all of the traditional medical teams that have had, quite honestly, not a lot of background and training in empathic language, or to Wilka's coursework, studying what symbolic language was. I wanted to ask the two of you before we turn over to Joan, or the three of you, Ken, Liz, and Andrew, what do you feel would be a next step for our medical community as we emerge through? I don't think we're going to be finished with this COVID time anytime soon, at least not here in the States. What would you encourage the medical communities to do to improve total care or palliative care, and provide the most humane experience for families that are not able to access their loved ones, or for those that are facing true trauma and suffering as they cope with COVID?
Well, I'll jump in. For me, I think my mother was always about education. I mean, we've got to go in and start at the beginning, because once you get to the middle of your career, you're already kind of programmed, and it's not too late, but it's much harder to start later in life. You've got to start early in medical school and expose people to the concept that death is not that frightening, that is something we should digest, we should talk about publicly in a healthy way, and this is not happening. So we've got to get it into the schools, into the medical schools, talk about death, palliative care, talk about grief. And we've got to intercede earlier in people who are going into this field, because without that, it's almost hopeless, because once you're in your 40s, there's, it's really hard to reprogram doctors to sit down in the bed of a patient and hold their hand and have a conversation. They're already programmed us to get through as many patients as possible. So I think Elisabeth will say, change the whole education system.
I think that makes absolute sense, doesn't it? And I think the other thing, of course, to recognize is that in the lived experience of most practitioners, whatever role they're in, whether that's in chaplaincy or social work, whether that's a psychologist or a counsellor, a doctor or a nurse, we've never experienced anything quite like this before. Because ultimately, when most people pitch up at hospital or at the GP surgery or at a health centre, they know what to do. But at this point, of course, you're firing in the dark and shooting in the dark and trying to find out how can we support this person, what is it that we can give, hence all the treatments that have been sort of quickly rolled out as people have tried different things to enable somebody to hopefully survive coronavirus or have minimized side effects or effect of the illness. So I think that's a big thing too, and we need to recognize that for practitioners there is suffering in that, and I'm not sure that we've acknowledged that. What we acknowledge is, so far I think, is the suffering of those who are coming towards the end of their life and their need for palliative care with all that it brings. But I don't think we've taken a step back to say, but what do we need to offer those who are providing it? And delivering it? How can we support these men and women in their different roles to be able to fully support those who are indeed coming to the end of their lives potentially, or who are taking a long time to recover out of ICU and then into back into a ward before discharge? How do we support families who are not allowed into a hospital? How do we even find ways in which we can manage for families to come into a hospital or a hospice to see people? Someone who has a COVID diagnosis. So, you know, we're still struggling with that. We're dealing with it biologically, which I think is what Ken has sort of said, with the need to go back to training, because that's where, you know, a lot of things start if you've got people who are hardwired and aren't going to change. But we need to recognize too, what do these people who are experiencing this on the other side need?
Well, spot on. I agree. Liz, do you have anything you want to add to that?
Well, I agree, and I already said I think it should. I think even Cicely was saying that, you know, this should be undergraduate training for professionals. But I think also there's something about you know, learning relational care. So, you know, that actually a lot of medical, nursing, maybe not so much social work training, but certainly doctors and nurses don't learn from the beginning about their own relationship with themselves and their understanding that, you know, they bring into their relationship with their patients who they are as persons. So I think that's one thing. You know, how much work do undergraduate doctors and nurses do on their own motivation to be in that role, and how that impacts on their resilience, and you know, and also I think, you know, how do they take care of themselves? So I think what Andrew's saying is absolutely right, that, you know, the fact that people should be surprised that they're impacted by suffering and death, and therefore detach themselves from the people they're caring from. Again, you know, Cicely talked about, you know, the fact that people, it would be a bit like walking through water and not getting wet. We have to acknowledge that to be alongside anyone, alongside a person, and to listen to them so that you can facilitate and empower and enable them rather than fix them, means you have to experience with them some of that suffering. And then what do we do with that? You know, how are we equipped from, you know, med school or nursing school to take care of ourselves? So yeah, I think we've yeah, we've lost the ability, I think, not just within medicine, but just generally in society, the ability to engage in real relationships with one another and recognize that that is costly, but it's also deeply rewarding. You know, it's yeah.
No, it's true. You're spot on. And I'm going to bring up one more aspect to that. But first, I'd like to invite Joan. Joan, you were going to do a reading and then to ask you a question about the legacy and of both just incredible women. And then I'm going to close for us and ask you both one more question. Joan?
Yes, I would love to read you this poem that I found when I was writing a history of the children's hospice and palliative care movement. And I found when I was interviewing leaders in the field of children's palliative care, that the two names that came up most often for their influence were Cicely Saunders and Elisabeth Kübler-Ross. And this poem, I think, brings together so many themes that you have identified in this discussion this afternoon here in South Africa. It's called We Build on Foundations We Did Not Lay, and it was written by Reverend Peter Spillman-Rabley. He wrote, "We build on foundations we did not lay. We warm ourselves by fires we did not light. We sit in the shade of trees we did not plant. We drink from wells we did not dig, and we profit from persons we did not know. We are ever bound in community. May it always be so. This is as it should be. Together we are more than any one person could be. Together we can build across the generations. Together we can renew our hope and faith in the life that is yet to unfold. Together can heed the call to a ministry of care and justice. We are ever bound in community. May it always be so."
Beautiful. Beautiful, and something beautiful for us to ponder as we go to our next question of building, right? You know, one of the things that we've talked a great deal about was the medical community and, you know, just what they're going through, the need for change, the past. But I'd like us now to look forward. I'd like to invite the three of you to discuss your individual organizations in 2 to 3 minutes, just how you see your organizations moving forward. Of course, you know, a website to tell them so that people can find your information. But I'd also like you, as you're speaking, to address the fact that our future will rely upon the children that we have now. Our own deaths will rely upon death experience, will rely upon either our grandchildren or our children or the younger adults that are learning and growing. One of the concepts I've had is to increase death education as a part of everyday education. We teach children in high school about birth, but heaven forbid we ever talk to them about death. So how do we, through St. Christopher's Hospice and through the Elisabeth Kübler-Ross Foundation, address this fact that we're not going to change this immediately in a year? But what do you see your individual organizations doing to look forward, to provide a shift in this space, while also too caring for everyday people, you know, who need and respond and want care as they face end of life? Liz, would you and Andrew like to go first?
Liz.
Yeah, I was going to say, I'll talk about education. If Andrew perhaps can talk about the new care model at St. Christopher's. Yes. I think it's really important. So as Director of Education and Training, I was in post for the 50th anniversary of St. Christopher's. And there was a real sense of we need to reflect, we need to we need to recognise and celebrate the achievements of Cicely Saunders, but we also need to evaluate whether you know, we're continuing to go in the right direction. And I think what we've all talked about is the importance of education. So St Christopher's was set up, you know, Cicely right from the beginning recognised it wasn't just about delivering a new model of care, it was about making sure that was evidence-based, and huge amount of lots of research, the most meaningful being qualitative, being listening, you know, listening to the dying person, their family, and that on which the model was founded, and then disseminating that new knowledge through education. So I think the conclusion we came to was that we really needed a new vision for education at St Christopher's, which has resulted in a new building. A new building which is much more fit for purpose. The space has been specially designed by architects, having looked at what we're currently delivering. And we are very focused on participatory learning, learning that empowers the learner. This idea that, again, we should be listening to the learner, listening to what people are trying to achieve in their own culture, their own context, and enabling. So it's not about teaching people how to do it. It's about saying, okay, this is what we've learnt, but you need to interpret that, translate it, and then make sense of it, and then apply it as you see fit in your own context. So we're very excited about our new education vision, strategy. It's going to be launching later this year. And, you know, ironically, I think we've also learned over the last few months that it's not, we don't just need a building, we actually are using technology, but in a very face-to-face way. So small groups, making relationships. It's about relational learning, therapeutic learning. But it's very much part of an overall care model, which Andrew will quickly tell you about.
Yes, I mean, I want to tell you that I'm sort of sitting about 10 yards away from the building where I am at the moment. And it's looking really quite spectacular, although we've not been allowed in it yet because the builders still have it. I mean, when we began to think about what our future priorities were, we, with Heather Richardson, who's one of our joint chief executives, created a thing called CTT, the Care Transition Team, as we began to really think about how we wanted not just the education model to develop, but also how we wanted many other things about us to develop. And we looked at how we give care to people and why. And we recognized that our focus, of course, was on those who are on our books. And on any one day, there's about 1,200 people on our books. Of those, about 1,170 will be at home or in care homes, because that's the model to which we work. Our hospice is not that big, our number of beds is not that large. And we realized that we needed to focus our efforts not simply on a traditional IPU ward-based model, but on really developing the skills of carers and family members and healthcare professionals who are working in the community as much as those who are working within hospitals or hospices or palliative care units. And beyond that, we also recognize that we needed to focus our efforts on making contact and influencing the general public. Because the general public, generationally, if we can access them, can have an enormous, be an enormous driver for change. Whether that's the right word, I'm not sure, but let's stick with it. To be more resilient around death and dying, to be able to talk about death and dying, to recognize death as a universal concept, to understand that somebody can support a neighbor or a friend, and it's okay. It's not a difficult thing to do, but it just takes your willingness and your generosity and your friendship. And so our care model really is a triangle, if you can imagine Maslow's hierarchy of need, at which caring for patients is the smallest bit at the top. Below that, we have care for support for healthcare professionals and others who come into the care model to support people professionally, then care and support for family members, friends and carers, informal carers, and then of course the general public. So a triangle where the broadest base is the people where we want to influence change in the community. And that, I think, is absolutely fundamental to a successful future, so that we are not simply saying we are the experts and the professionals to whom you must come. We are saying, you know, people who need support, you can do this support. We can help you now to generate your resilience and your understanding and your sense of awareness across generations. You talked, Diane, about children, school children, and I think so. We want to engage with children and young adults, people going into caring, social care and healthcare professionals, all kinds of different levels, as well as people who live around and about us and beyond, because they are the people who will experience death and may never come into contact with a hospice or a palliative care unit. But they will know somebody who lives close to them or who's next to them or a relative. So the care model in itself is now pushing down, if you like, beyond the group at the very top who are in need of care, who we won't abandon because they're most important to us, but we're pushing down to say we can influence societal change, which we know will take time. And that means that we are making a long-term commitment.
Beautiful, and thank you. Thank you to both of you, but thank you to your organization as well. You know, that is my personal commitment for the rest of my life, is to try to create movement and a shift in terms of societal change on the consumer level. Because the medical community, much of the language and conversation is circular, and I say that respectfully. There are IDT meetings, there are associations, there are large organizations, but on a consumer level, we know through research and data that also too, that if we can create a societal shift, which by the way, you took my last question, so thank you, which was how are we going to create a societal shift? You're doing it. And I can speak, you know, with the Elisabeth Kübler-Ross Foundation, and Ken, I'll ask you to address this too. The Elisabeth Kübler-Ross Foundation would love to support what you're doing. We are fans of this type of work. We understand and support what the consumer movement is and the impact that consumerism can have. Imagine a world where consumers walk into their oncologist, i.e. labeled patients or family members. They go into their oncologist, and if they don't receive a palliative care referral, they ask for it. And if they don't get it, they demand it. And if they don't get it, then they say, it's my right, which is a lot of what My Care, what is it today? We're called a care game.
My Care, My Comfort.
My Care, My Comfort. So, you know, imagine that shift becomes global. Ken, on that note, I'm going to turn it over to you. What do you think that your mom would see or would say looking forward? And what do you see the Elisabeth Kübler-Ross Foundation doing going forward?
Well, as you know, Dan, in the last 2 years, I think we've really focused on diversity. I think that's a real big issue in the United States. Unfortunately, the model is all based towards kind of the Anglo-Saxon view of how hospice should be culturally and educationally and every other way. And I think Elisabeth's message was very universal, very multicultural. So we've started about a dozen different international chapters, principally in Latin America, but we have groups in Asia and Europe as well. And we're just focusing on Elisabeth's intention of dealing with the disenfranchised people, you know, the people who don't have a voice. And 50 years ago, that was every dying patient. But now, you know, we have some care, you know, in the United States and Western society, but in third world countries, it's shocking how little care they have. And so we're really focusing on producing programming and education in Spanish and other languages. We're doing things in Flemish, in French, and Japanese. And I think we need to focus on the diversity. And given this explosion of, you know, Zoom calls and all this, it's a beautiful opportunity for the foundation to be able to take speakers in the United States, so we wouldn't have the money necessarily to fly down to Peru and Guatemala and Brazil and different places. But now it's practically free. And so the chances for us all to connect and share ideas is incredible. And so we're opening up, more and more groups in South America. We have new groups coming up in Argentina, Uruguay, Bolivia, Colombia, and we're going to look back towards Europe next year. And it's just a wonderful time to focus on the marginalized populations around the world who are not receiving the care, whether it's because it's not in their language, it's not part of their culture, they're indigenous people. We're going to start our first international chapter run by an indigenous person in northern Brazil, by an Amazonian next year. So very excited about that. And we're just looking to diversify and not just have one message, but realize the world needs many forms of message and people take it in different forms. So we're going to focus on that, and we're going to focus on our collaboration with St. Christopher's, which we're very excited about, and form other collaborations around the world.
Thank you. Thank you. And thanks to all of you. Joan, would you like to help us close now?
Yes, well, first of all, I would like to say a really thank you to all of our panelists and to you, Diane, to Liz, to Andrew, and to Ken. It has been for me a most fascinating conversation. I think that the message that Dame Cicely and Elisabeth Kübler-Ross sent out was really about connection, about the person and their story being so important, and about unconditional love. And I really also want to thank all of those around the world who are working to provide palliative care, often in really difficult situations, and who are bringing the light of their presence and their compassion. And as we say today on World Hospice and Palliative Care, bringing this idea to every single person that they can ask for my care and my comfort. So thank you again to everyone. And this will be available on YouTube and will be up on the Elisabeth Kübler-Ross Foundation website, Ken. And we do hope this is the beginning of many conversations where we build on the legacy and we take it forward with new ideas, new vision, and new energy.
Excellent.
I'd just like to add, we have a few questions from our audience, so maybe they can write us individually and we'll answer them. And I'd also like to thank Wilke and Rodrigo for setting this up and helping us with the technology and getting this started.
Yes,
Right.
and also to Ken's point about the Q&A. So I can stay on for a few minutes. Ken, can you stay on? Can you all stay on, Liz? And I'll just we'll just do an impromptu for those of you that want to sign off. Good day, and thank you for joining us. I will do a quick Q&A, and I'll read the question, and then you guys, whoever wants to answer it. One of the questions was, we've isolated ourselves, and the virus has accentuated greater isolation. It's a two-edged sword. What do you guys have to say about that? Anybody?
Well, we live in a society that I think this is Western society, which is very much based upon the individual and the autonomy of the individual. And autonomy is great because we are making our own decisions and making choices in whichever way that is. But actually, when something like coronavirus happens, when we are not in control, we find ourselves absolutely in that place where we are indeed isolated because our relationships are so limited. I can remember my grandmother, for example, talking about knowing everyone in her street, and my mother would have said the same. But now I have to say I do not know the people I live in the same block of flats with. So there is isolationism that I think has developed over time as we become more and more busy. We become more and more autonomous. We no longer see ourselves connected as a society. I guess in this country, some would blame Margaret Thatcher for saying there is no such thing as society. There are individuals and families, which is not true. If we're not a society, what are we? So we need, if this can help us with anything, it is to find those ways in which we can make connections with each other. And we can support each other. We can do simple things that bring us back into a sense of simple, nodding to your neighbor as you leave for work, asking if they need some help, just saying that you might need some help, beginning to make connections with each other again, being human to each other, absolutely being human to each other.
Yeah, I think we have to be.
Okay.
Sorry, I was just going to say, I think we have to be careful because actually in low and middle income countries, this isn't the issue that it is in our high income countries, where we've become, wealth brings independence and, a sense that you don't need other people. And, we do, obviously, I remember last year we had one of our international programs and we had a nurse from Guyana. And when I was talking to her about our new care model and how we had such an issue around loneliness and isolation in our society, and that we were needing to sort of re-engage with our community, she looked at me as if that's just not a problem in my country. She said, when I can visit my patients maybe once a month, and who do you think looks after them in the meantime? The community, their family. So, I think we just have to recognize that this is our problem, that we need to have humility and recognize that, in fact, we do need one another. And we need to reconnect and learn how to engage with one another again. Sorry, Ken.
No. I'm going to circle back again to Elisabeth's view that, everything in life is perspective. The lesson she learned from the concentration camps, which is the same as in logotherapy, is that, you choose one's attitude in a given set of circumstances. So, Elisabeth would say, okay, well, you're isolated, but this is a great time to focus on your family, focus inside, focus on education, learning, improving yourself. Everything in life is an opportunity. And even being isolated is an opportunity, but it's based on your perspective of what you do with these lessons. So it's a challenging time, but it's also a time for us to grow if we choose to.
And that's what one of the respondents was saying. And also too, that very message was a part of a mainframe of Viktor Frankl's, expansive work in Man's Search for Meaning, is that, it's up to us to choose our thoughts and our feelings and how we react to difficulty and hardship. Who else? Oh, someone asked the name of the poet and the poem that Joan read. Joan, can you share that?
Yes, it's, I'll put it into the chat, but it was "We build on foundations we did not lay." And the poet is Reverend Peter Spillman Ribley, but I will put it into the chat box.
Thank you.
And then there was a question about insurance, Diane?
Yes, and I can't scroll back up, Wilka, help. I know, I said, I'm typing while one of you was talking. I promise I'll come back to it. Help. If you're still on, whoever wrote the question about insurance, I would love to address it.
I've got it. Do you want me to read it? It says, how can we change the practice to provide empathic communication when insurance companies set the limits for a physician's time with a patient?
Ooh, there goes the mystery of the universe.
How many hours do we have?
Again, you see, that's a specifically, I think, specifically American issue. And I'm not saying it's not the same. In the UK, it's also a problem in that appointment times are limited because the health service is under pressure. But it's not dictated by insurance companies, obviously, but by the pressure to see lots of patients. So I don't know, we need a revolt, we need a revolution. We need, we need to say, actually, sorry, we've got our priorities all wrong.
Mm-hmm.
Well, I think some of that is changing, and that has to do with care models and CMS. And I mean, I can address a little teeny portion of that, but a little teeny portion of that has to do with primary care providers. And that is beginning to shift here in the States as having more of a role within the overall continuum of a care model. That also has to do with value-based care. I mean, the CMS runs the bus when it comes to payment models, how many patients, it's a very complex formula. Not
Diane,
that I am
interject?
Yeah, one sec. And then the gist of it, though, is that things are shifting, but to your point about consumerism, I think the more consumers grow in their voice, I think it will make a difference. Ken, sure, go ahead.
I'm not a Zoom expert, but I've scheduled this for an hour and a half, and we're at 1 hour, 29 minutes and 14 seconds. So it may cut us off in 42 seconds. So
No, it won't. It
No?
won't.
Okay.
If you're paying for the for Zoom, it won't cut you off. You can
I've been
carry
on
on.
calls where it just totally cut off.
Yeah. Well, I say that, but
Okay, so just
I
in
think you
case
might be all right.
it's not
Yeah,
me.
I think you might.
Sorry to interrupt, Diane, but
Oh, you can interrupt anytime.
okay.
So the gist is that it's that I agree with all of you. We have a long way to go, but it doesn't answer the basic question besides the payment model and the number of patients any clinician is supposed to see in an hour. That is human behavior, and that is compassion and empathy and ego and control, and that's all of these other things that Elisabeth and Cicely spoke about. And also we raised the topic here today, but realizing that clinicians are people too. They are seeing profound trauma and difficulties, and many of them had education or coursework on communication and training and communicating with compassion, and they're on a time crunch and they have their own stuff they're dealing with. I know that we don't have the answer, but I do feel that it's something that, I don't know, maybe we can discuss it going forward, because it's a really wonderful question. And to your point, it is a largely US based issue in terms of payment models and such, but I think it's something that we can discuss most certainly if you all like at some point. Sorry, I don't think that answered your question very well, but.
I don't think there is an answer. I mean, it's a long, complicated.
No, but there is also something about, you were talking about communication, learning communication skills. It's not just about communication, is it? Because communication skills training can be very, what's the word? Sorry?
Antiseptic.
Yes, exactly. And actually what we're talking about is being able to respond compassionately to someone, not worry too much about the words that come out of your mouth, more about how you communicate you care about that person. There isn't a formula to how to communicate. But I also think that a lot of clinicians say, well, I haven't got time to have the conversation. Whereas we know, don't you, if you make a real connection with someone, you can just have 5 minutes. And I was really interested in, I think Cicely made the observation that Elisabeth was able to have a meaningful conversation in an hour. And Cicely was taking, several days, several months, and they were basically getting to the same place, but they were using the time that they had. I think that's really interesting. So if you've only got 10 minutes with a patient, how can you communicate real attention, real listening, that you really care about them and that you will actually not abandon them and you will respond to what you hear them telling you. And if you've only got 10 minutes, you have to use that well. And that actually is, it requires you even more to be aware of your own responses and needs, but also to look after yourself, because that level of attention is very intense and but could be very beneficial and really meaningful for the patient that you're listening to.
Brilliant, spot on. I think that wraps our questions. Joan, do you want to sign off for us?
Just once again to say thank you. It's been a wonderful conversation. I think there's just so much learning that has come out of it. And I think the message of really unconditional love that came from both of them is something that we need to take forward in whatever we do, whether it's this time of COVID or just in our life as it goes forward in every day. So thank you to each one of you, to Liz, to Andrew, to Ken, to Diane, to Wilka and Wendy, and to all of you out there listening. Please join us again when we have our next conversation, and please check the St. Christopher's Hospice website and the Elisabeth Kübler-Ross global website. Thank you.
Thank you very much,
Thank you
everybody.
very much. Thank you.
Bye-bye.
Thank you. Bye-bye.
Bye, everyone.
Bye.